Burns are common in the children's emergency setting. We want to give them the best chance of healing well and to manage the child's pain quickly and effectively. After initial cooling for 20 minutes under cool running water, deroofing is the next step. It's important that we get this right because it has an impact on outcome and comfort. How do we do that safely and smoothly? I'm going to show you how I deroof burns so that you can be prepared next time one comes into your department. So why do we deroof burn blisters? Well, we want to firstly prevent uncontrolled rupture of the blister. We want to relieve pain in tense blisters. We want to reduce restriction of movement over joints. We want to remove any non-viable tissue, avoid the risk of blister infection, and importantly, to enable the assessment of burn depth. Burn blister deroofing means removing the burn blister and any fluid and non-viable tissue. All blisters bigger than the size of the child's little fingernail should be deroofed. Deroofing should happen preferably on the day of injury or on the day that you first see them to avoid readherence of non-viable tissue to the wound bed. You'll just need a few simple pieces of equipment: a wound dressing pack, some sterile gauze, some sterile water or saline, some scissors and forceps, and don't forget to bring a dressing with you to put on afterwards. How are we going to deroof those burns? First of all, always give adequate analgesia before you start deroofing a burn. This is a painful procedure. You must allow time for the analgesia to take effect before you start. And usually this really means that you need opiate analgesia, such as nasal diamorphine or fentanyl. If the child is able, they can also use nitrous oxide during the procedure. Get the parent to give the child a cuddle if it's practical given the burn area, and involve your play specialist or someone else to provide a good level of distraction. Children with extensive burns may need sedation for deroofing and dressing. Before you start, clean the area with water or saline. For thin-walled, fairly flat blisters, you can use mechanical debridement with moist or dry gauze. Dry gauze can make it easier to catch on to blistered skin. And when using this mechanical deroofing technique, be firm, be quick, and make each pass count. For thicker walled and more bulbous blisters, you can use sharp dissection with scissors or forceps. For filled, raised fingertip blisters, you can fenestrate those by cutting a window in the blister to release pressure and allow you to visualize the wound bed. Snip any tense blisters, drain the fluid and cut away the dead or devitalized tissue carefully up to, but not including, the margin of sensate tissue. Remember that the burn will be more painful once the blister has been deroofed and the wound bed and therefore nerve endings have been exposed to air. At this point, you need to be able to make a quick and accurate estimation of area and depth and take photos to send to the burns unit and to keep on the child's record. Cover the burn with a dressing as soon as deroofing has been completed.